right now. Can you see now?
Can you give us a thumbs up or any notice?
Yes, we can see you just fine.
All right. So that was just a little, I wanted to use a brief example of the interpretation, because even though bilingual individuals are able to speak, English and so on and so forth, they at times prefer to receive their medical care in their mother tongue or in their language of preference, because it's a critical time when a person comes into the hospital, and therefore they don't want to, or they perceive the extra effort in trying to understand every word is not warranted in their location, and therefore they require, request, or suggest the use of medical interpreters. So let me tell you a little bit of how I got into this aspects of DEI and my advocacy for LEP patients and the use of professional medical interpreters. So 2001, I moved to the United States with my wife. My wife was pregnant with being in a immigration, the visa processing for our masters for about 2 years, and in between we got pregnant. We landed actually in Atlanta in July 2001, July 6, 2001, and pregnant with a due date of December 31st of that year. What happened was shortly thereafter, September 7th, my wife Viviana started with some issues. We went to the hospital thinking we were going to come in and out, and the doctor said, no, you're not going anywhere. You're actually in active labor. You're past the surclash. You're past all that. You have to stay in the hospital in bed rest until you deliver on December 31st. This was September 7th. And oh, by the way, the doctor also said, and it's highly unlikely the baby will come to terms. So at the end of the day, we delivered Nico, 7 days later at 23 weeks of gestational age. And what happened was we had to stay in the hospital until January the next year. Now, during that time, our physicians and the nurse team would tell us, baby Tambasco is great because of you. Baby Tambasco is doing great because of you. Little by little, we started noticing that it wasn't because of us, but it was because of our circumstance. We were bilingual. We were highly educated. We were able to advocate for each other and for our baby. Therefore, it wasn't so much, or part of the outcome was because of our ability. The reason I connect the story is because we were used, this was 2001 again, the law wasn't as enforced and so on and so forth. So the care team at the intensive care unit in that facility, a great facility, by the way, started using us as interpreters for other couples that were limited English proficient. And under that scenario and with that experience, we actually learned so much of the barriers that came in play. Not only the language, but the literacy level. You see, you doctors spend 10, 12, 15 years learning a very complex language to then have conversations with us, the patients. So it's important that in using and in managing these conversations, we understand both the barriers of the language itself, but also the nuances of the culture and the nuances of the culture and the literacy level. So today, Nico is perfectly a healthy young man after being born at 1 pound and 8 ounces and so on and so forth. So this experience motivated me to get into healthcare. I didn't know what I would do back then, but that's where I started at the American Cancer Society. Later, I worked at Parkland Health and Hospital System in Dallas, as you heard, and most recently in Boston. So what we lived in that intensive care unit certainly had been research, and many various studies support this aspect of patient and practitioner concordance, particularly when it comes to language concordance. It increases interpersonal care, medical comprehension, likelihood of keeping follow-up appointments, and adhering to treatment plans. You know, the same article that the Rationale for Diversity in Healthcare Professions also speaks to, and others speak to the impact of race and ethnicity concordance between patient and practitioners, but that's not the topic of today, but it definitely impacts, or the studies suggest that there's a correlation and impact in them. So we know there is an impact on interpersonal care, medical comprehension, and likelihood of keeping follow-up appointments when the practitioner and the patient have language concordance. Now, that's not always the case. We can't always ensure that. So this is where the role of the professional medical interpreter comes in. Let me tell you actually a little bit more. It used to be that originally medical interpretation or interpretation services in healthcare facilities was deemed a patient satisfaction service, right? Later on, we started learning that it was really not only a patient satisfaction service, but it actually had, as we saw before, impact on outcomes and experience. And also, by the way, it had a connection with safety incidents and with patient quality and safety incidents and results, right? Suggesting that adverse events that affect limited English proficiency patients tend to be more frequently caused by communication problems and more likely to result in serious harm when compared to English-speaking patients. So as you see here, 49% of LEP patients' adverse events involve some physical harm versus 30% for patients who speak English. What else? Of those, half of them had some level of temporary to death, including death, harm. And lastly, more likely to be the result of communication errors. So studies like this is not a recent, this was first done, I think, in 2007 and then published later on and so on and so forth. Studies like this started shifting the focus to patient safety. And let me give you an example, and you'll see this little bubble here of scenarios as we move throughout the conversation. One of the conversations that is most commonly is shared when we talk about safety incidents is the case in Florida where the patient went into the hospital, a relative brings them into the ER, and somehow in the communication, the patient in Spanish says, "Mi hijo está intoxicado," my son is intoxicated. That was interpreted as intoxicated. People thought DUI, people thought, drug or alcohol use or so on and so forth. And treatment was delayed because they were waiting for the patient to actually sleep it off or whatever the expression was used. The issue was the term, and this is a very common term used in Venezuela. I'm originally from Venezuela. When we refer to the term intoxicado, we were referring to actually indigestion, that something didn't sit well with us in the stomach. We ate, or even we had an allergic reaction to some food. That whole case, patient died, that whole case ended up in a lawsuit, millions of dollars exchanged hand. This is one of the typical, but not the only of its kind. Actually, when we looked at, these are examples that you read about. Let me share examples that I participated in. Back at one of the organizations I worked for, when we first looked at reportable safety incidents by limited English proficiency patients versus non-limited English proficient patients, we understood a couple of things. One, we understood that the number one reportable incident for all patients, when looked at all patients, was related to IV fluid and medication. When we took out and we stratified the data by limited English proficiency patients, what we realized was two things. Their volume was small compared to overall patient population. So in this instance, we had about 10% of our patients were limited English proficiency. And that meant that in the data without stratification, it wouldn't show up evidently, right? So when we stratified, the number one reportable safety incident for our limited English proficiency patients had to do or was related to care coordination. Our limited English proficiency patients were falling through the cracks. And we only noticed that when we actually stratified our safety data that way. Let me move on. So when we talk about and continuing this aspect of safety, according to our Census Bureau, there's approximately 9% of our population who's limited English proficient, and that comes out of the fact, which language, the questions around what is the language spoken at home, and so on and so forth. 21% does not have high English proficiency, and again, our population in general continues to diversify, with Asian and Hispanic communities being the fastest growing. And all this indicating that the encounters with limited English proficiency patients are only more likely to occur. Certainly, LEP patients have greater difficulty understanding discharge instructions, medication use, dosage, so on and so forth, even follow-up appointments. And lastly, there's a few studies that speak to the use of trained medical interpreters and its impact on reducing errors in care. And by the way, this is related to errors in care when compared to using family members or untrained medical interpreters, right? So I'm trying to initially discuss a little bit of the foundation as to why we do this. But when it comes to our entity, right? When it comes to our organization, when we look at Emory Healthcare, top 3 languages that are interpreted: Spanish, 60% of the calls are in Spanish; Vietnamese, 7%; Korean, about roughly also 7%. We conduct about 67,000 phone and video interpretation calls and approximately 1 million minutes, all right? And this is at Emory Healthcare and the Emory Clinic, both, and in-person encounters, which are tending to be in our, in Midtown, University Hospital, UWash, the Wesley Woods Rehab and Hospital, and the hospital-based clinics, right? When these, in these operating units, our in-person encounters over a period of a year, always June 2021 to June 2022, was about 4,000 encounters or 265,000 minutes, with approximately 2,200 LEP and deaf patients, unique patients being seen by our teams here. So again, the issue of, in a setting like us, they don't seem, I've worked in places where 63% of our patients were limited English proficiency, and that's where I led probably one of the largest interpretation programs in the country, with about 100 in-person interpreters and 10 million minutes of video remote interpretation through vendors. But again, I'm calling your attention because one of the things we need to understand is that we can't rely on reports as they are today to identify limited English proficiency patients, because statistically, the N is small. Now, when it comes to our data, which by the way, let me talk first about this example here. So Dr. Mayer, Williams, Swift, and Matthew are actually working on a project where they determined, or they identified, that LEP patients stayed in our hospitals approximately 3 days longer after elective colorectal surgery. So really, and even beyond the conclusion, if you look at some of the findings, I think are probably even more clarify the opportunities here. 75% were consented for operation without documented interpreters. So LEP patients, 75% of them were consented without a documented interpreter. 75% had durable medical equipment and teaching needs at discharge, right? 50% had no documented use of interpreters postoperatively, and 0% had daily documentation of interpreter services. right? So 0 of them we were able to track effectively. Did we actually provide interpretation services on every day of their stay? So there are proposed interventions certainly around identifying the patients, what are the resources, how do we optimize language services, how do we document and track this data. So the team working with EMITS, our interpretation services at Emory, and our access teams are looking to define new scripting for data intake, for patient data intake, the procedures around these interventions. And as a secondary effect of the QI project, we're looking to reduce length of stay, which, by the way, is not only speaks to the outcomes, the health outcomes of the patients, but also speak to our financial results. Lastly, and in setting up the context here, we all have seen social determinants of health, social drivers of health. The point here, so yeah, economic stability, neighborhood and physical environment, education, food security, so on and so forth. When it comes to healthcare system, the Kaiser Family Foundation suggests that access to linguistically and culturally appropriate and respectful care is a contributor to healthcare disparities. So this lack of linguistical capability by our providers or our system is somehow impacting the health of our patients. And let me share a scenario here. This is, again, not a textbook example. This is an example of a previous organization I worked on where we understood, or we did a short study there to understand who was going to our integrative therapy center. And we found out that out of approximately 7,000 limited English proficiency patients, 9, and only 9, had gone to our integrative therapy centers, right? And when we started looking into it, what we realized was this. The way we promoted this SACM Center was through our care teams sharing the information with our patients. There is some indication that in an effort to reduce the complexity of the conversation when it was being interpreted, our providers were limiting the information, right, that was shared with patient to that was deemed most critical to the care and the situation at hand. In other words, I'd rather tell you and spend time going over your medication and how you're going to take it and so on and so forth than reminding you, hey, by the way, you can also get Reiki, nutrition, or massage therapy in our integrative care services. So again, only 9 patients had gone in that year, and 8 of them were taken by their hand to the center by a social worker that was bilingual. So what else, although our LEP patients are coming to our facilities and are experiencing all the greatness of our science and care, what are they missing because it's invisible to them, because somehow it gets lost in translation? This is, I think, the least impactful of the reasons why we do this, but just a reminder that absolutely there's a legal framework that mandates us having to provide medical interpretation, both Title VI of the Civil Rights Act, the Affordable Care Act, Section 1557. Ultimately, we got to provide meaningful access to LEP individuals. That's what one says, and the other one amplifies. And also the cultural and linguistically appropriate service standards are part of this framework that makes us have to provide language interpretation services. Now, I hope that the reasons that you understand are critical to drive this effort across this institution and any other, is more of the impact to the patient and actually in the consult. So let me tell you, when we think about medical interpreters, and this is all leading up to why do we use trained versus non-trained and so on and so forth. When we think of interpretation, one aspect that trained interpreters do is this aspect of mediation, where they're thinking perhaps culturally, I need to raise my hand, make it clear in the conversation that I'm not at that point translating word to word what is said, but I'm suggesting we use a different word or something based on what I know in the culture of the patient. And again, culture is not as random as we think. There's a series of patterns that are observable over a continuum. So ultimately, culture, when you think about it, it's hierarchical or egalitarian. It's either group or individualistic. So if you're seeing Hispanic patients, you'll tend to see, at least if you're seeing patients in my family, right, you'll tend to see that we come in groups. Mom and dad never go alone. It's always one of our 3 siblings coming. We try to build a great interpersonal relationship with the provider, and our communication, tends to be indirect, and I'll share a couple of examples of why this matters. But time is fluid, right? For Hispanics, it's a little bit more fluid. So perhaps if you're asking, when did this start, might not get to that date right away, but I might have to go back and say, hey, I remember that was when La Tia came, or that was around Christmas, and so on and so forth. So culture has a role to play. And out of all of this, because today's conversation is not 100% on culture, is that these dimensions, when you look at different cultures, all right, and please avoid stereotyping. You'll always find a Hispanic that does not behave like this, and so on and so forth, right? But what I want you to focus on is on these little gaps, right? So for example, if my communication style, right, is direct, like the US communication style, very direct, Hispanic communication style, a little bit more indirect. This green gap here can produce or impacts the dynamic of the conversation, all right? This aspect of hierarchy, right? This gap here also impacts the dynamic. Let me share an example. Dad receiving care, prostate cancer care here at Emory a few years back, 2007. We come and the doctor says, yep, you have prostate cancer, and here are 5 options for you: cryotherapy, prostatectomy, simply observe it, and the radioactive pellets inside your organisms and things like that. So he shared 5 therapies, and my dad went back and said, okay, this is great. What do you recommend? And the doctor says, well, the 5-year survival rate on all of these are the same. So really you can't go wrong with anything you decide. My dad says, all right. And he's saying this through me. I was interpreting actually, which is not what we recommend. And Dad says, all right, and what would you do if it was you? Says, well, my situation is different, blah, blah, blah. Doctor says, long story short, we never got a direct answer from the doctor, because the doctor was, based on how we do things here in the US, empowering the patient with information to make decisions. My dad was wanting a doctor that would, right, based on my dad's culture, that would share perhaps what they would do so that my dad would make a decision, not necessarily for the doctor to make the decision. So these kind of gaps of locus of control and empowerment generate a dynamic. And then when you add an interpreter, it gets even a little bit more complex. And that's all I wanted to share about cultures. But let me tell you, the way to actually reduce risk here is through the use of professional medical interpreters, because not only they're certified and there's education that comes tied to it, there's a code of ethics, and they really are required and hold very dearly this principle of we're accurately interpreting what both the provider and the patient are saying during the encounter. That is what they do. Yes, they have a role in mitigating, all right, and of a cultural ambassador or so on and so forth. But if they're going to deviate from what is strictly being said, they're going to let it be known before they start that aspect of the conversation. They help clarify. So for example, if you're talking about renal failure and the patient is not understanding that, maybe the interpreter will come and say, doctor, could you please use more of a different term for renal failure? And then we would use, kidneys, and then that's an easier way to interpret or to interpret for the patient. Lastly, again, they're transparent. They're maintaining neutrality and confidentiality, and will make it clear when mediating. So let me share this video, which at the beginning we agreed we were going to do it in a different way. We're going to stop sharing this. We are going to share this, and I will need someone to tell me it is working and that you can hear it.
Mrs. Chen, I'm Dr. Franklin.
It's working.
With you, we use your son as the interpreter. Just gets too complicated to connect to our people, and we'd have to wait, so if you don't mind.
妈，我帮你翻译。
哦，你的英文讲得这么好，我的儿子他有电脑的学位 sample， 他从小就把我翻译的。
We can use me.
Great. As you know, we've been treating you for quite some time with chemotherapy, and you've done really well. Your cancer is under control, but as I've told you before, we can't cure it. And I am a little bit concerned that your spleen is enlarged.
医生说，他们有药可以医你的癌症。他也说你的胃比较大。
这是好消息，真是好消息！谢谢医生，谢谢医生，我很高兴。
Okay. I'd like to do some tests to see what's going on and give you some new medication. Now, this new medication might give you stomach upset, so if it does, please let us know and we'll give you something for it. Now, I know you're in pain, so it's really important that we control the pain so you can have a good quality of life. So please let us know if your pain is not controlled.
Okay.
All right, we'll fax the prescription to the pharmacy.
那他在讲什么？
他说我们要去药房去拿你的药。
Great.
All right. So the encounter actually, again, reinforces while the use of an interpreter while the use of the interpreter is, if you have no other resources available, I think the law allows you as a last resort to use a person. But again, the preference is to use a trained medical interpreter to avoid scenarios like that, which, by the way, don't think these are exaggerations for purposes of teaching that our friends at the Stanford School of Medicine put into this video. Let me share with you a couple of things. Countless times at Dana-Farber, our interpreters were asked by family members not to interpret the word cancer. Both at Dana-Farber and at my previous employer, where I recall an incident where the physician was on vacation, knew, the physician on call, the provider on call, took the patient on that day, and eventually asked the patient, you are aware that this is a terminal disease you're going through, and so on and so forth. Do you have advanced directives and so on? Can we help you with end-of-life planning? That was the first time the patient clearly understood that that was the case, because in previous interactions, the patients had been interpreted with by family members, and they had been avoiding the use of terms like terminal illness and so on and so forth. Even when our interpreters were utilized, they forced the interpreter somehow, not that they forced, even when the interpreter would say it, some other relatives in the room would try to soften the pill, as we say, to explain, well, that's not really what they mean. Now, let me tell you something. Remember, I've been talking about my dad and my mom and how we take care of them. And by the way, my dad, until he retired, he lived in Venezuela. He's the CEO of a company. So don't think of this very vulnerable person, because he's not. But when he is at the doctor, he understands there is a hierarchy there. He seeks the advice of the doctor, and he will never tell the doctor he doesn't understand or ask a question. I don't know why. I try to ask him, I try to get him to prepare before we come, but he will never. And in a conversation with him, he said, I don't ask questions because I know that if I didn't get something clear, one of you, my kids in the room, would have understood it, and we can talk about it when we get home. So this aspect of teach back and paraphrasing and all of that not always applies. All right, that's let me now go back and share again, and we're almost at the end here of the conversation. Let's see if this works again, because now I'm going to have to do this again. All right, can you see are the slides on?
Yes.
Yes.
All right. So when we think of these encounters, and by the way, this tends to happen naturally, and no one thinks of these as different phases. But in my experience, many times some of these things are skipped, right? There's according to industry best practice, there should be a pre-conference. And what that is just a brief encounter between the provider and the interpreter. Patient's not in the room. Hey, we're going to go see this patient. Here's a little bit of the background. And oh, by the way, this is what I want to achieve in this conversation. I want to get consent for this. I want to, they need to clearly understand that baby's not doing fine, or so on and so forth. All right, that can take 2-3 minutes, 1 minute, depending on it. But please, it's recommended not to skip it, because it gives the interpreter a background as to what the experience will be. Then once we are in the consult, right, the interpreter will briefly again say, hey, after the introductions, I'm here, I'm Ildemaro, I'll be doing the medical interpretation for you. Please understand that I will interpret everything I say. And they say this both in English and the language they're interpreter, so everyone in the room is clear. Please understand, I'll interpret everything you say. And if you don't want me to interpret something, you don't say it. Because once you say it, I have to interpret. And oh, by the way, if I think there's a better way, or if I think there's a dynamic at play here that is impacting the conversation, I will make it clear, hey, this is not what is being said by either of you, but XYZ. Perhaps it's easier if we use a different word. Let me give you some context in the culture as to what that means. All right, that's the brief pre-session right with the patient in the room. Then the interpretation happens during the session, interpretation and mediation when necessary. And lastly, the post-session, which is many times not used. All right, but this is where the provider and the interpreter check in. And as a fan of data collection, I would say, make sure that post-session interpreter usage is recorded, and we verify that language preference is recorded, and so on and so forth. Let me share an example. And I saw in the chat, I saw a question or a comment there that I'll respond when I'm able to see the chat. Here's a scenario, not exactly about technically all these aspects, but we have two things. We have medical interpreter comes in the room with a provider. Patient's going to go into surgery. Patient is Jehovah's Witness, and their belief says we will not accept transfusion. So patient is asked, hey, there's an increased likelihood that you will need, well, actually, the doctor didn't even say that. The doctor said, you will need blood transfusion during the procedure, or your life is at risk, in so many words, right? Would you accept, or would you authorize us to? Interpreter communicates, interprets for the patient. Patient looks at interpreter, looks at husband in the room, looks at another person in the room, and says, no, I don't need, I will not authorize you to give me a transfusion, or whatever the right words are. All right. This conversation goes on with the rest of the instructions or the rest of the interaction. And when they're stepping out, the interpreter, after they stepped out of the room, the interpreter tells the provider, you know what, there's something about this encounter that I don't feel comfortable with. I believe the patient was trying to tell me something else. Is it okay if we come back? Provider says, you know what, let's do it. Let's wait until the person's not in the room or the person's alone in the room. Well, they came back around 45 minutes. Still, the room was full of other people, so they did not ask the question there. But what they had the presence of mind doing was, as the patient, the provider said, we will not start anesthetic procedures in the room. Let's wait until the person's on its way to the OR. Behind closed doors, the interpreter again asks the question, hey, by the way, just to make sure, we're going to ask you again, would you authorize us to do transfusion? And the patient loud and clearly says, of course, I want a transfusion. I could not tell you this in front of my husband or my brother from the church, because this is not what we are expected to do. But yes, I want the transfusion. So long story short, we changed a little bit of the procedure to ensure these kinds of questions were either patients alone or behind closed doors, where then we had the control of the patient being alone or not. All right. So lastly, on our call to action here is a couple of things. One, use the qualified medical interpreter, as it says down there, even if you know enough of a second language, a couple of words or so on and so forth. They're nice. We tend to think that they will, create empathy and a good environment in a good dynamic in the consults. But it's always best to use the qualified medical interpreter. You can become a qualified bilingual provider if you speak a different language. We just need, for purposes of compliance, to ensure that everyone's deemed qualified. And I know, right, some of you would tell us, oh my gosh, but I went to undergrad in Spanish. How now you're asking me to take a test or whatever? But it's actually a requirement, not by us. Conduct pre and post sessions. Do try to use the pre and post sessions. Make sure we record the use of interpreters in the system. This with Epic, we are optimizing this. I didn't have the time to add the screen, but there will be a screenshot in Epic that will clearly identify individuals that are limited English proficient. When rounding, if you're rounding your patients, or if you're an executive and rounding patients in general, make sure that you use an interpreter so that you can round on limited English proficiency patients. We learned a lot when that happens. And lastly, practice good positioning. And positioning refers to, and I must have skipped this, positioning refers to the physical location of the individuals in the room. Long story short, we want the interpreter to basically not be obstructing the conversation. Two techniques there: either the interpreter slightly behind the provider, so the provider doesn't run the risk of looking or speaking to the interpreter versus the patient, or interpreter slightly behind the patient. So again, out of sight. And even if the provider looks around, patient might understand that they're there. So positioning, the conversation is never with the interpreter, and the interpreter should be basically invisible for the discussion. Now, if you want to understand, or if you have doubts around what kind of services you have available, how do we do interpretation support? If you go into the intranet, and if you look for Emory Medical Interpretation and Translation Services, the department, you'll find these tiles. And when you click on each of them, they will direct you to what are the resources available, and if you need to schedule inpatient interpretation, so on and so forth. Right now, our interpretation services are not centralized, or let me just say, different operating units do it differently, and we have opportunities there. So with that, I will now open it up for questions and comments.
Okay, thank you so much, Ildemaro, for this presentation. Dr. DeSandre had a comment he made about just the initial patient that you described, the options for prostate cancer treatment options. He said, sounds like the doctor may have neglected to engage in a dialogue to offer a values-based recommendation. Each option has pros and cons.
Yeah.
Yeah.
You know, this was my dad, and eventually we ended up going to a different facility who's more used to international patients somewhere in Texas. And again, I continue to believe that while our physician here was going above and beyond in explaining, because they did explain the benefits, pros, the cons, all of that. What my father was looking for was, this is what I would do if this was my father or if it was me. When we changed providers, and I'm being direct here just for the benefit of the learning, we went to that other place, and the physician, after 45 minutes, you know, physician, so on and so forth, provider looking at options, they say, hey, here are the options, 1, 2, 3, and I would recommend we do, and I forgot the technical term, but I don't know, it's called like patient's observance or something like that, which means we're going to check it, we're going to continue to observe it. And my dad, I remember that day as if it was yesterday. My dad came out of that consult and said, finally, I got someone that speaks to me directly. And he picked up the phone in the waiting room and he called all his peers in Venezuela and said, this is the place you need to come when you're in need, right? And by the way, he commented on the puzzles and the fish tanks and all of that. But so what I learned is that, because, you know, the system itself also enables or discourages these conversations. So when they were interpreted conversations, actually they were the system understood it was going to take longer, so it actually credited as 2 patients, as you had seen 2 patients when you're using an interpreter for one of these initial consults, so on and so forth. All right.
Thank you. Another question someone asked in the Q&A is, can you speak on best practice between phone interpreters versus in person? The quality of phone interpreters seems so much lower than in person. And then a second question to that Dr. Ryan Smith asked is, and do you have a way of recommending or convincing patients when they refuse a phone interpreter in place of a family member?
Well, so a couple of things, and I see, you know, I had a daughter insisted on interpreting. Flat out, we say our policy is this. That's what our interpreters would say in other places. Our policy in the law says we need to provide the medical interpreter. Your son or daughter or you know, family or loved one is, if you authorize them, they can stay in the room, they can double check, but I have to use medical interpreters. So there is places that actually do this according to the law. They don't hesitate in that conversation. So that's the second part. But the first part, video remote interpretation versus in-person interpretation. I'm not going to be objective here because I have a bias for in-person interpretation. And actually, let me tell you this. I have a bias for organizations having their own interpreters, even when their own interpreters provide video remote interpretation. So for example, Maria and some of her colleagues provide video remote interpretation from our facilities. They are still our interpreter. We control the quality, we control the training. They're used to seeing our patients. And by the way, let's say Maria is a Spanish interpreter, so we understand and get used to the Spanish that is predominantly spoken by our patients. So there are instances, absolutely, video remote interpretation is necessary. We don't have enough bandwidth to do everything in person. And actually, in our practices, we had this aspect of, we would agree with a department what kind of encounters would need in person versus video remote by an external vendor. That was a decision by the service providers, the department, and we would follow that matrix. So for example, consents at Parkland were always in person. Family meetings, baby's not doing good, and they're called family conferences or whatever, those were always in person. If we're going to diagnose, if we're going to talk end of life, they were always in person. I tell you, video remote interpretation in our geriatric services didn't work at all. Issues, technology, the hard of hearing, so on and so forth. And oh, by the way, if we're talking about palliative care, let me tell you, you cannot get my dad to talk hospice, to understand that concept, to understand, they will not. So the interpreter, the in-person interpreter is valuable. What is the advantage of the video remote interpretation is that, you know, it gives access to the masses if you don't have enough staff. Maria, anything you want to compliment there? Because
Yeah, I would say that we have to just focus on each individual patient. Unfortunately, the first appointment, you are a little bit at a loss, but you know after the first appointment who this patient is and what they need, and you can plan ahead. So it's not like I am going to use video interpretation only, or in these circumstances, which is very correct. What Ildemaro is saying, that depending on the situation, but it is also depending on the patient. And some patients, and that's also why having the same interpreter, because not only the doctor, but the interpreter is able to judge, is this working? While we do over the phone interpretation, very often we are interpreting, and then I am in the hospital doing over the phone interpretation, and I realize this is not working. Maybe the doctor is not realizing, but this is not going very well. And I say, doctor, can I run? I will be there in 5 minutes, and I go to the patient's room. So the providers and the interpreters and the patients have to come to an agreement of what works and what doesn't. And once you realize that the patient has difficulty using the phone or video, you just have to provide in person.
I see a question. Okay, go ahead.
Yeah, go ahead. Is there a question in particular that you wanted to answer?
How are efforts to implement medical interpreters monitored for quality control, given the nuances you described around the use of colloquial language or other cultural aspects? Again, our trained medical interpreters, based on their code of ethics, will not interpret outside of what is being said. If they're going to suggest something, if they're going to mediate, they will let it be known to both parties. They would say, doctor, this is not what the patient said, but I believe you could use different terms here. Would you, the interpreter will not produce the terms. The interpreter will ask the provider, could you use different words to explain this? And then the interpreter will interpret.
I think the other question is, some languages and dialects have no available medical interpreter. How do you recommend responding to this situation?
Okay, so Maria, Maria, you want to start? I saw you starting to, and then I'll chat in.
I just, you know, we do a lot of different things. One of them dispatch, and we get requests, and we will give our life to make sure that we would get an in-person interpreter, but sometimes it's hard. I can tell you I have worked for Emory 5 years, and there might have been 4 times that I'm aware where we have had to talk to the family and have had to tell them, unfortunately, we have not been able to find an interpreter. Only 4 times, maximum 5. So first of all, be aware that we have a lot of resources. And again, different operating units have different resources. And I am not very familiar with all the operating units, but ours, we work with many agencies that provide contract interpreters. CIRACOM offers 200 or more languages. So first of all, make sure that you exhaust all the alternatives. And second, if you find out after that there is no interpreter, available. You talk to the family or anybody who is bilingual and can interpret for the patient and use them. Unfortunately, you will have to use them as interpreters, and with their help, you convey to the patient. Unfortunately, we have done following the law and trying to help as much as we can. We are not able to find a qualified interpreter for communicating with you, and we are asking whether you all, family members and patient, would be okay communicating through family. And the patient has never said, oh, no, this is not possible. I really demand a qualified interpreter. And also, I have to add that the law never says that you have to provide a qualified interpreter for the 6,000 languages available in the world. It just says that every institution, depending on the resources of the institution and many other factors, has to do their best effort and work hard at providing the services. So again, we didn't fall outside of the law in those situations, so we don't have to be worried because there are 6,000 languages or more. So that's what we have been doing. In those cases, we have to do that. And also, very importantly, for liability issues, we have to document what our efforts were and why eventually we couldn't find the qualified interpreter. And we have to have the patient sign indicating that the agreement, what happened, and indicating I acknowledge that this is what is happening. Thank you.
So, this typically, or the instances where I've seen it happen, one, indigenous dialects from Hispanic countries that people initially perceive, oh, a person Hispanic, they're going to speak Spanish. There are dialects there. And we have found the interpreters, it takes time. So again, this is situational. If you're in the emergency room and you don't have time, once you've checked in with our services, checked in with a video remote interpretation, you move on to the family or the relative. But if it's a planned family conference, we'll do our best. The other scenario is sign language. I don't know if it's common knowledge that American Sign Language is not universal. And in many cases, people actually do gesticulation as opposed to a language. So that kind of nuance is a little bit hard to get. Any other thoughts or questions? I know we're at time.
I think, I think we answered everybody's questions in the Q&A. Thank you so much for presenting at our inaugural grand rounds. Thank you, Maria, for also participating, and for everybody who made it happen. Thank you so much.
Happy to be here.
Thank you.
All right, I work with palliative care team at Shoah.
Thank you so much, Ildemaro.
All right.
That was amazing.
Yeah.
Thank
you,
you.
everyone.
You're getting a lot of love on Twitter.
Oh, that was great. That was great.
Oh, Kim, did you post a link to Twitter?
I did. It was posted several times, and I posted your fantastic slide.
Oh, wonderful.
Yeah, so that the great breakdown. So that was extraordinarily helpful.
Yeah.
I'm gonna go ahead and stop the recording.